Thank you. Very nice to be here and having me here in Gothenburg. So, yes, Mattias Paulsson from Lytics, and we're working with preventive care for value-based care, which is a healthcare paradigm that we don't yet have here in Scandinavia. It's starting to show here, but it's more predominant in the US. And Lytics as a company, we have a heritage where we come from the consumer market and the telecom market. So we had another company that were sold to eBay that worked with big international companies in Japan and the US. So it was very natural for us to go to the US and start working in the US. We started working with chronic diseases when we founded Lytics and sort of validated that we could do some good in this field. And very soon we started looking for the market where we could find a product. And about 4.5 years ago, we identified the dialysis market and started working there. And the dialysis market is very, very interesting. So they suffer from end-stage renal disease, which is a very specific, very particular disease, but they're also multi-sick. These are the sickest patients in the entire healthcare sector. And in the US, 1 out of 7 have chronic kidney disease, which will sooner or later evolve into end-stage renal disease. And the cost is very high. It's about 8% of the US healthcare budget by itself. And the hospitalization is about 2% of that, or 2% of all the costs. So it is an issue. And also it's concerning how the dialysis industry is operating. They had what they called the bundle, where they moved away from fee-for-service into a bundled payment, putting more pressure on the clinics. And we started getting into this field when we learned about the ESCO, which is a great abbreviation because it stands for End-Stage Renal Disease Seamless Care Organization. And this is the very first specific care organization, and care organization is kind of like value-based care, and it's a great thriving thing in the US. So we were there from the beginning in this ESCO field and started working there. And Centers for Medicare and Medicaid, they hold this ESCO program as the golden standard for future care. So we figured why not be there in the beginning and learn how to operate in this model. And also due to climate change, end-stage renal disease is on the rise. So this might be a little bit small text, but at least we can see the headlines here. So we see the healthcare paradigm as moving away from fee-for-service and new public management that we still have here in Sweden towards value-based reimbursement, which we see in the States. And already this year, about half of all the payments coming from the payers in the US are tagged with value-based care. So you're getting penalized if you don't have high quality. And that's where we come into the part. And then, of course, we have the full capitation, where you would have insurance companies or third-party associates, or it could be the government, where you take the full responsibility for a patient. And in this kind of environment, it becomes even more important with intelligence, such as we can bring to the table. So we launched a product, it's called Lytics Ver. We love to teach Americans to say Ver, it's very, very fun. And this is a simple dashboard as it seems here. On the right side, you can see up here, we show a lot of factors, variables that are important to those making the decisions. We also have an AI score, so we're making calculations on patients on a daily basis. So the recipient of this program are care managers, which is a certain profession whose only job is to prevent hospitalizations with these patients. And they typically have 70 to 100 patients that they care for. And they try to do a triage of these patients on a weekly basis. Who should I focus on in preventing them from getting admitted to a hospital? And this tool is something that helps them and cuts down their time of being the detective of reading journals, which are not really made for that detective work. So we identify the high-risk patients and we deliver it to these care managers. And this is very much work in progression, I would say, where we sort of do a continuous fortification. And we add on features all the time to help these nurses make a better decision. We've seen one of the learnings that we have is it's a little bit of a lottery. The more experienced the nurses, the more qualified, it's easier it is to do preventive work. Very, say, novice nurses, they take this and they say, I don't know what to do with Mr. Wilson. He's flagged as number 1, but I really don't know what to do. Whereas a more skilled nurse would say, Mr. Wilson, okay, I looked at his blood pressure, I looked at his drug medication, I talked to the doctor, and then I figured out, and then I blah, 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 blah. And that's so much easier for them to do the preventive care. So I think we need to take a step further into the preventions as well. And we've carried out a trial in Cleveland, Ohio over the last 8 months for 600 patients in such an ESCO program. And we've seen some statistically significant results in our favor. We do cut down time on hospitalizations and also the cost of the patients. But again, causality is very, very difficult here because there's such a big change or big difference from individual patients to other patients. Looking at the trend, and these are data from the Centers for Dialysis Care in Cleveland, we look at the general hospitalization rate on days per month, and we can see the pink line is the trend on other patients, so that's the general patient population. Then we look at this 8-month window, we have the ESCO patients that are managed traditionally by the nurses, and they decrease a little bit, the hospitalization rate. But the patients that are being managed by our care is a significant decrease. You actually never see the other patient groups going down to that level. So this is a good sign and a promise, I think, to continue investing in this technology, and that's what we're intending to do. So we're right now negotiating with 2 of the dialysis clinics in the US and intend to move further. It's a very concentrated industry. If you go to the 10 largest dialysis organizations in the US, then you capture 95% of the market. So it's a small world, really. And how do we accomplish what we do? Well, we capture the data, and I'm so happy that Kaiku Health was presenting before, because they do quite the opposite of we do. They get their data from the patients, which we would love to do as well. We just get the clinical data, so physiological variables. And we get it from the electronic health record, we get it from the care management's health record, we get it from statewide health information exchange, which is a database on a state level where you have all the hospitalization data. And then we run machine learning on that, and we teach our system, which is a self-learning system. We also get data from the dialysis machines. And we plug this data into our server, and then we refresh it on a daily basis for these patients. So every day you can see who is the highest on your risk list. Which also means that if you're starting doing preventing measures, you can see how the patients moves on that list, sort of drop on the high risk ranking. And that's pretty much it.